Good evening, everybody. My name is Gina Francis Makwabe. I would like to welcome you all today to our usual AHN Nephrology Educational webinar, and today's series number 66. My name is Gina Francis Makwabe, and I am the consultant nephrologist and physician working in Tanzania. I'll be chairing this session. And today's topic is an overview of renal dietetics and preventing CKD progression in ADPKD with ketogenic diet. So it's a pleasure, great honor and pleasure to welcome our today's speaker, who is very experienced in nutrition and in this topic. She's called Teresa Rodriguez. She's a certified nutritional support dietitian and a National Board of Nutritional Support Clinician. She's also a certified LEAP therapist and Integrative and Functional Nutrition Academy. So Teresa, you are warmly welcome. And for today's session, we have the audience from over Africa. As I speak, I'm from Tanzania, but we have audience from Uganda, Kenya, Rwanda, Mozambique, South Africa, and all over Africa. So you are warmly welcome, and please proceed with your presentation.
Thank you so much for the invitation. For me, it's an honor to present to you today about PKD. I'm gonna start, maybe some of you today, they're thinking, oh my gosh, how she's gonna talk about ketogenic diet? What is ketogenic diet? You know, how about, is possible, to help people with PKD with ketogenic diet or nutrition intervention? After many 6 years ago, my life changed when I was getting blind. I was 48 years old. I was getting blind. And at that time, I started to learn more about ketogenic diet. And since then, I would say that my life changed. Not only my life changed, my personal experience gave me the opportunity to learn more about ketogenic diet. And now I'm using that therapy for many diseases. And 2 years ago, I'm sure that maybe your aha moment is today. 2 years ago, when I went to the Metabolic Health Summit, that conference that we mostly, healthcare professionals that know or want to learn more about ketogenic diet, we meet there. And then when I was there, I hear, like, for a second, I was like, oh my gosh, I hear for a second that they were doing using ketogenic diet for polycystic kidney disease. And I was that, oh my gosh, is this serious? That was my first aha moment in the relation between ketogenic diet and polycystic kidney disease. I've been working as a dietitian for 28 years and as a renal dietitian. And as you know, polycystic kidney disease, what is polycystic kidney disease? I would like to review with you for a second what it is. It's a lot of cysts filled with fluids, right? I want you to understand, or today in my presentation, catch a lot of key points. We found out 2 years ago that polycystic kidney disease is a metabolic disease. And I want you to understand and visualize that when we talk about metabolic disease or metabolic in general, what it happens every time that I eat something, any foods that I eat, I can turn the switch on and off, on the progression of any pathways or stop the pathway in the way that will stop or control that disease in particular. And we're gonna go more in details about it. Polycystic kidney disease is the most inherent kidney disease affecting one of 800 people. But right now I have cases that is not secondary to from the parents or from family. It's not necessary to be a genetic, like coming from parents or family. The three main classes of PKD, today we're going to talk about autosomal dominant PKD. That's the most common. It affects 1 of every 400 to 1,000 people. We have ADPKD1 or ADPKD2, and we have the recessive. It's really rare and happens in children and happens in 1 of 20,000 people. And again, I want to tell you that until 2 years ago, being a dietitian, a renal dietitian for many years, was not until that aha moment that in my mind, I have only that the only possible treatment for PKD was dialysis and transplantation, and that changed. And maybe for you today, it's going to change that concept. And that's the reason that I want to spread the word about that, about it's no more dialysis or transplantation, and you're going to see how we can help with that. Because recent studies at that time, in 2019, they say it's a metabolic defect. These changes in metabolic disruptions of the mitochondrial function impair fatty acid metabolism and dependence of glucolysis. I want you to visualize that they understand that, the cells of in the polycystic kidney disease, especially in the tubules, they are very dependent of glucose. Okay. And then as this cell become more dependent of glucose, their source of energies, and it appears to be unable or inefficient or not flexible when we use ketone bodies as energy source. For a second, visualize, okay, we're using glucose all the time as an energy source, and the cells, they start to grow, right? The cells start to grow. However, when they changed, I would say the gas for ketones bodies, they're not flexible. They were not able to switch, and that's the reason that they noticed that they stopped the progression of the disease. There are two main doctors in the world doing research. One is Dr. Muller in Cologne, Germany, and then one is Dr. Weems in Santa Barbara, California. And they proved that the induction of nutritional ketosis through time-restricted eating, fasting, or the use of ketogenic diet inhibits the cyst growth, renal fibrosis, and prevent the loss of kidney function in several different animal models like mice, rats, and cats of PKD. Scientific data, I will just show you what Dr. Muller and Dr. Thomas Weems has been found in this studies that they did. Consistent with this finding, individual with ADPKD and type 2 diabetes have a significant greater total kidney volume, more than those with ADPKD. I want you to visualize that if you have diabetes, it's going to be more risk for you to increase the cyst, and furthermore, increase the progression of the disease. Patients overweight, patients obese, patients with diabetes type 2, they have more rapid progression in early stage of ADPKD. Taking together these research results established the conclusion that renal cysts in PKD depend on glucose as the main energy of energy. And that these cells are metabolic inflexible and cannot adapt well to metabolic shift that occurs in ketosis. Again, visualize the cyst start to grow and grow and grow. If we give it to them more glucose and stop that, if we change to ketosis, it's going to stop. Furthermore, they found out that the intracellular calcium level was low in patients with polycystic kidney disease. Not only at cell level was low too in the mitochondrial level, in the mitochondria, and that will induce to further kidney or progression of PKD. Tonight or today, I don't know, for me it's the morning, for you but I would like for you to visualize what is the relation, how nutrition can stop this, especially these two pathways, that in the way that can you visualize what we can do to stop the progression of PKD. I'm going to talk about CCAM, or cyclic form of adenosine monophosphatase, and mTOR pathway. And then I will show you how if we manipulate these pathways, especially, we can turn the progression of the disease. Everything we know that start on the tubules of the patients, you know, or the kidneys, and then if we turn this pathway on, obviously, it's going to start the progression of the disease. Let's see about CCAM, or adenyl cyclase pathway activation. It's like, just visualize like it's switch on. Okay, a stress, based on a study, a stress can increase the progression of that. Vasopressin increase when high sodium levels in the blood and decrease water intake, and we're gonna see that. Prostaglandin, if we control inflammation, we will be able to control the progression of the disease. And how we can do that? We can turn that off if we follow low carbohydrate ketogenic diet, omega-3 fatty acid, phytonutrients, and I'm going to talk more about it later, curcumin, ginger, boswellia. And also, because I mentioned before that they found that calcium is low, not only at cellular level, at mitochondrial level too. We need to monitor closely the pH and vitamin D status of our patient. And most of the research are agreed that the target of vitamin D, it should be at least 50. In terms of mTOR, we know mTOR is the pathway that regulates the cell growth, proliferation, survival, and metabolic problems. This regulation of mTOR, we know by study, not only it has a relation with PKD, has a relation with acute kidney injury, renal fibrosis, glomerular disease, and kidney cancer. And how we can turn the switch of mTOR down, right? How we can turn that off. Study shows that we follow carbohydrate restriction, ketogenic diet, time restriction, and intermittent fasting. You can decrease the progression of that, or turn mTOR off. Moderate protein intake and exercise, and some studies show metformin too, but I'm not going there. But it's another. They're doing more study about it. But if you think for a second, we use metformin to control glucose level, right? Or insulin resistant. More research, again, I would say if you're obese, you have hyperglycemia, you have type 2 diabetes, you are increasing the risk, if you have the diagnosis of PKD, for the progression of the disease. In animal studies, a slight reduction of food intake inhibit the growth of the cyst in mice. Another technique that we can use is calorie restriction, intermittent fasting. This is nothing new. I would say that since 2016, the Mayo Clinic already proved that if we do a calorie restriction, of 40% of the calories, you can decrease the progression of the disease. But you're going to see later on that it's not only the reduction or, of the calorie restriction. You're going to see that it's more things that we have to pay attention. Supplementation of beta-hydroxybutyrate exogenous ketones replicates the beneficial effects of dietary restrictions. And we're going to talk more about it. Again, two main researchers in the world is Dr. Muller in Germany and Dr. Thomas Weems in California. I think this was a study that changed everything, how visualized PKD. And in this study in 2019, December, has been 2 years since then. It proved that ketosis prevents and reverses PKD in animal models. Dietary changes may induce ketosis will prevent polycystic kidney disease. Oral or supplementation with beta-hydroxybutyrate inhibit PKD progression. And since cells are not flexible, which can stop the progression. If you see the picture here, if you follow low carb, high carb diet, you see that they have more and more cysts, right? However, in this study, they proved that they follow ketogenic diet, they follow intermittent fasting, or they supplement for 5 weeks. They did it for 5 weeks with exogenous ketones. That will stop. You see, it's no cyst in that kidney. This means I want you to visualize that if you go more glucose, if you use glucose as an energy source, you're going to start the progression of the cyst growth. If you use ketones, obviously, you're going to stop the progression. Ketogenic diet, you're going to say, oh my goodness, what is ketogenic diet? And ketogenic diet is nothing new. We just, we were supposed to celebrate this year, in January of this year in California, the 100 years of a ketogenic diet. Has been ketogenic, it's not a new treatment, has been 100 years. We hope that we're going to celebrate in Santa Barbara, California on May the next year. Everything started in 1921 when Dr. Russell started to use ketogenic diet to treat epilepsy. And then the popularity decreased in 1938 because there were more medications for epilepsy. But everything started again when they say, and they realize that if the patient was on 2 or more medication for epilepsy, to add ketogenic diet, it helped them more. And that's the reason that came popular again in 1971. We have different kind of ketogenic diet. I want you to visualize ketogenic diet is not one single ketogenic diet. All depend on the treatment or the patient or the disease is how we treat the, or adapt the ketogenic diet. In 2000, Dr. Kossoff created the modified Atkins diets because they realize that they don't have to be too strict in terms of carbohydrate restrictions to see the benefits of the epilepsy, decrease the epilepsy episodes. And then they adapt to the low glycemic index as another treatment. Right now, ketogenic is not available in over 45 countries. In 2010 was when they start to use ketogenic diet in patients or diseases that other than epilepsy. And let me tell you, it has been amazing for us to use ketogenic diet. As soon as that happens to me, and I realize how ketogenic diet changed my life, I start using that in many diseases. And this is the diseases or the list that we have studies done. And for example, diabetes. We know that 90% of the people with diabetes, you can reverse diabetes if you treat them with low carb or ketogenic diet. Again, but as I said before, as a dietitian, I have to look for like single patient. As a functional dietitian, I have to look the whole picture of what's happening with a particular patient. Sometimes I cannot apply what is in research in general to everyone, because that is what I provide. I provide personalized ketogenic diet, and you're gonna see that. You're gonna see, look, maybe you see a picture of a patient with PKD, and you only visualize that you look at the kidneys, right? Or what's happening to the kidneys. This is my picture of what I look when I see a PKD patient. If I don't see these factors, what is happening with this patient, with each single patient that came to me, I'm not doing anything, because I'm not covering all the bases. When I see, I'm really fortunate that here in the US, I can do genetic testing. And we not only have here genetic testing to, to tell me which problems they have and how we can change it, what we call nutrigenomics, how we change it with some foods that we can be able to turn on and off that pathways. We do genetic testing, and we do genetic testing for more than PKD. Just in general, we do for diabetes, hypertension. It's one genetic testing that tests you for 365 genes. And you can visualize the risk that you have, not only for PKD, that you already have it, you can see diabetes or other hypertension or all the things, SNPs there. And then we have to check what kind of exercise, lifestyle the patients have, because when you have a lifestyle, the way that you eat and you follow your normal lifestyle, you're turning your genes on and off. Inflammation, the patient is inflammation, the patient has an episode of acute kidney injury. How is the gut? It's a big relation between the microbiome and obviously the kidney disease. Hydration, salt, fasting, how is the pH? Not only the pH in blood or the pH in urine. One of the biggest concern, and is less recognized here in the US, is oxalate problems. I don't know if you guys have a lot of problems with oxalates there, but it's a big issue, because oxalates, if you have a problem with oxalates until you don't fix it, it could be a genetic problem or it could be environmental problem. I'm going to talk about that. How we manage phosphorus, magnesium, ketogenic diet, the micronutrients, the vitamins, all of this is what I visualize when I see a PKD patient or a patient in general. Again, based on these studies, they found a time-restricted diet. When we talk about intermittent fasting, and I want you to be clarified with that, the difference between time-restricted diet versus intermittent fasting. Time-restricted diet is like, let's say I stop at 7 p.m. today, I'm eating, I will not eat until 7 a.m. I will be 12 hours without any foods. And then I will have a window or 12 hours to eat. That is what most of the people are doing. Intermittent fasting, not necessarily I would do that. I can be days not eating, and then some days eating, and even patients, they follow like a regular diet and ketogenic diet. These are the techniques that we use to reach nutritional ketosis. Again, most of the studies has been done with what we call classic ketogenic diet. And what is the difference between the classic ketogenic diet versus the standard American diet? Carb intake in a standard American diet is 50%, and ketogenic is only 5%. In terms of fat, the standard American diet is 34%, and keto is 75%. And protein in a standard American diet, or the SAD diet that we call here, SAD, because it's really sad when you follow that, is 16% and protein 20%. And I want you to understand that every time that you change, you know, when I went to college in the 1980s, I learned like, okay, calorie in, calorie out, that is all that you have to do to keep, you know, in balance your body. Now everything changed, because it's not only that. What you eat, if you eat more carbs, is what is going to impact your glucose level, your insulin levels. And that's the reason that will increase the progression of your disease. This means that I want you to have this in your mind. The type of foods in terms of insulin response is what is really matters. It's not calories in, calories out. It's the type of foods that you eat. If you increase the carbohydrate intake, obviously, you are going to increase the insulin secretion. You're going to decrease inflammation. You're going to, this is the way that I explain to my patients, and I'm going to explain to you quickly this. When I explain to the patients about energy source that you can use, you have to waste. It's like you gas station. You have to waste. You have the gas or you have the diesel, right? When you use the gas, like it's the carbohydrate, the sugars, what happened? Every time that you eat carbohydrates or sugar, you're increasing insulin, you're increasing inflammation, you're increasing the sodium retention, you're increasing the fluid retention, and that's the reason that you see as soon as you stop eating a lot of carbs, you can reverse not only diabetes, you can reverse hypertension. And also you're increasing the risk of accumulation of fat in your liver, right? However, if you go to the diesel, that is the ketones body, obviously you don't need a lot of secretion of insulin. What is going to happen? Decrease inflammation, decrease the fluid retention, decrease the sodium retention. My patients call like a natural diuretic when you are following ketogenic diet. And also you decrease the accumulation of fat in your liver. And that's the reason that you can reverse fatty liver too. Again, this is a well-formulated ketogenic diet. All depend, I adjust this on the patient intake or a patient in general. Fat, usually 75 to 85% of the calories, but in my case, I use it only to keep balance. If they have to lose weight, I will adjust it. Mostly saturated or monosaturated fats rich on omega-3. Example of that is coconut oil, olive, avocado, ghee. In terms of proteins, I want you to understand that I see this as has been a critical care dietitian too. And for me to keep lean body mass is to keep lean body mass is a goal in your body, right? You can lose up to 1 kilo a day if you are in critical care. And that's the reason that obviously I reinforce the use of protein in your intake. Obviously it has to be high quality, organic mostly. If you cannot, we can just look other options. Example, you can use plant-based protein. You can use any kind of source of protein that you really like. Carbs, 3 to 10% of the calories. We are going to encourage like low carbohydrate or vegetable or non-starchy vegetables, okay? Berries are okay. They're high on phytonutrients and they're high, lower in terms of, the calories. In terms of this, not everyone, and this is what I want to, and I see on PKD patients, is when I do the genetics, most of them, they're intolerant to lactose. And when they're intolerant to lactose, not only they're intolerant to lactose, they are deficient in B6. And when I see that pattern, I 100% of my patients that they have kidney stones, they are lactose intolerant and they have B6 deficiency in the genetic report. If they're lactose intolerant, I will not force the patients to eat anything with lactose, obviously, because it can cause more leaky gut. In that case, I will use, another source of calcium, and I will encourage the patient to avoid that. I want you to visualize when they say carbohydrate is like, we are going to avoid simple sugars. We're going to go more for complex carbohydrate and rich on fibers. Another way, simple way that we can do instead of the really strict ketogenic diet, and we see that is really efficient too, is the therapeutic carbohydrate restriction. And I see that if the patients follow at least 50 grams or less of carbohydrate daily, they can see changes in not only the formation of ketones, in weight loss, decreased inflammation. It's really interesting. Let's define ketosis or nutrition ketosis. Again, glucose is a primary source of energy for the cell, but when you are fasting or decrease the carbohydrate intake, you are going to increase the ketones production. And instead of use glucose as an energy source, you're using ketones as an energy source. There are three main kind of ketones bodies that you can use. Beta-hydroxybutyrate is the most common, and that is what I mostly recommend for my patients to monitor. Acetone is through your lungs, you can monitor that, and acetyl acid through your urine. And this is the way that we measure them. Beta-hydroxybutyrate, we use a meter. There are some meters that you can not only monitor your glucose, your ketones, you can monitor your glucose at the same time. You can use the same meter, and that is the ones that I like, and I recommend to my patients. Acetones through your lungs, I don't like to use that, mostly if the patient has history of lung problems, asthma, or any history of that, I would not recommend that. Acetyl acid excrete in the urines. You can use that, but remember, when you are keto adapted or you're using ketones as energy source, your levels are going to be low in urine, and you're like, maybe, oh my gosh, I'm not producing ketones. It's not that, that's not true. It's because your body is using already ketones as an energy source. How we define nutritional ketosis? If the ketones level are greater than 0.5, you're a nutritional ketosis. Nutritional ketosis is safe? Is the level that ketones bodies are producing in a small concentration without alteration in pH. And this is what most of the people, especially healthcare professionals, they are confused about. Oh my goodness, if I'm using ketones as energy source, I will have ketoacidosis. No, they're completely different, because nutrition ketosis, we manipulate the macros in turn to produce ketones in your body. When you have diabetes ketoacidosis, mostly we see that in diabetes type 1, and it's because obviously they're using insulin as to treat their diabetes. Right now, because we has been doing keto for PKD for almost, I would say, 18 months only. I was the first one in the world treating patients with PKD with ketogenic diet. Right now, we don't have the numbers, but in terms of what's the goal of nutrition ketosis, we know that to be nutrition ketosis inhibits the progression of the PKD. We, based on the only few studies that Dr. Wayne's has been done, has been seen that usually levels of 0.5 to 4.0 with a mean of 1.5, they see the benefits. I hope that soon we can see, that's the reason that we're collecting data to later on establish if we can see like glucose ketone index levels, goal level for patients. I want you to understand that the levels that we recommend for each patient is different. I want you to understand that you have a patient with epilepsy. My patient with epilepsy, if they are between 3 to 4 ketones level, they're fine. Cancer patients, mostly recommend in cancer patients to monitor the glucose ketone index. And in that case, we see that if glucose ketone index is less than 2, we see that stop the progression of the tumors, especially glioblastoma. All depend of the patient is our goal in terms of nutrition ketosis. So far, in PKD, levels above 0.5, you can see benefits. Other benefits of nutrition ketosis, I would say that nutrition ketosis changed my life, reduce inflammation, support mitochondrial health, increase energy, increase your life, increase mental focus, cognition, increase strength, and prevent muscle wasting, neuroprotective, lower blood glucose. Remember, if you're using ketones as energy source, your glucose levels are going to be down. Your insulin levels are going to be down. Support heart health. Most recent study shows that the heart love ketones too. And that's the when you think for a second, when we born and we use milk, breastfeed milk, what is going to happen? You're in ketone state, you're in nutrition ketosis. It's not until your mom add any foods to your to your daily routine or introduce the fruits or the veggies, or is when you change, instead of using ketones, to carbohydrate consumption. May improve mood, may suppress appetite. Not only study shows that in outpatient or in general, I has been working with kidney disease patient for 28 years, and I have seen every stage of kidney disease, acute kidney injury, hemo, PD, any stage, outpatient. And I want you to visualize that now we have studies that shows that not only benefits in outpatient setting, they benefits too in acute kidney injury. Ketones support kidney metabolism. Exogenous ketone, acute kidney injury could reverse that, decrease oxidative stress, inflammation, cell death, and fibrosis. Ketones obviously inhibit SGLT2 in the kidneys, and nutritional ketosis is a potential estrogen, find or way that we can manage kidney disease in acute kidney, even in acute kidney injury. And I know that more research are coming about it. Key components of personalized ketogenic diet for PKD. I want you to visualize it's not only one, ketogenic diet. It's personalized. Main focus is low fat as the main energy of calories, protein. Usually we provide between 0.8 grams per kilograms, carbohydrate, minimize the most that you can. Plant focus, this means that we're not going to restrict the consumption of animal foods. There are many reasons for that, especially B12 deficiency and other deficiency of amino acid that is not complete. Sodium restriction, hydration, bicarb, and citrate supplementation to keep pH in blood and urine correctly. Low oxalate, uric acid, and phosphate additive. Why? Because we have the combination of unbalanced pH and low oxalates, uric acid, and phosphate additive are increasing the risk for you to have microcrystal formations, and for that reason, increasing the progression of the PKD. Intermittent fasting on time diet and exogenous ketones, and most recently, I'm going to talk later about it, is the polyphenols. Protein, I'm going to cover the most important factors: protein, fluids, sodium, caffeine, and phosphate additive. Protein, internal plant versus animal, based on the research on the current guidelines, KDIGO guidelines, they're not, we cannot see any benefits of one from another one. It's a mix of them, okay? Moderate low protein reductions. Obviously, I want you to visualize that you have to keep protein in at least 0.8 grams per kilogram, because when you increase the protein intake, you are increasing mTOR, okay? Again, this is the recommendation between 0.8. In turn, if the patient is in a stage 1 to 3, I would go more, because I want to preserve lean body mass. Vasopressin and PKD, we know that vasopressin, when it's increase the osmolarity, increase the risk of the progression of the disease. One of the key points that we have to do is prevent we have to keep the patient hydration adequate. I want you to visualize more concentrate urine, more you are increasing the risk for the progression of the disease. And they know by study that vasopressin modulate the formation and growth of the cyst. What we recommend in terms of sodium, we know that high blood pressure and sodium intake will increase the progression of the disease too. And hypertension is the most common manifestation of PKD. Most of the patients, they have 50 to 70%. ADPKD patients are more sensitive to sodium. And I can see that in their genetic too. There are some SNPs that can tell us, if they're more sensitive for sodium, avoid sodium. Two large studies demonstrate that high sodium intake correlate with increased cyst growth and rapid progression of the kidney function damage. High sodium intake is associated with vasopressin release, which can impact the growth of the cyst. Based on the guidelines of the National Kidney Guidelines in the US, they recommend at least keep it less than 2,300 milligrams a day. How much water they can drink a day to prevent, again, to keep vasopressin and to keep the urine dilute. We recommend at least 3 to 4 liters of water a day. Water should be consumed through the day. Even at nighttime, if they wake up, we recommend to drink water to keep low the vasopressin levels. Urine should be pale in color. We want the dilute urine. It's important to increase the water intake with all meals. We want to keep the osmolarity in urine less than 280 milliosmolar per kilogram. And there are some formulas that if we have the 24 hours urine osmolarity results, we can calculate how much water they can have. This is one of the most controversial topic, caffeine. There are some studies, especially in the lab, that shows that caffeine can increase CKM. But clinical trials shows that caffeine intake was not associated with the progression of PKD. I believe, because I do genetic testing, that we have the gene too that can tell you if you're able to tolerate caffeine or no. If I have the genetic testing of that particular patient, if I know that they have positive for that, I would say you should avoid or you should minimize the consumption of caffeine. And we recommend less than 200 milligrams a day. And that is at least less than 2 cups of coffee and less than 4 cups of tea. One of the biggest concern that I have it for many years. When I work in a special in a hospital here, I did a study with one of my interns, and we just look about the phosphate additive, because everyone has a high phosphorus level hemodialysis, right? But I want you to understand that it's a big problem. It's a health problem that it covers many risks. For example, let's recap what is phosphate. We have 3 different sources. We have animal sources, the absorption is 60%, plant is 40%, but when you have the intake of phosphate additive, the absorption is 100%, which increase the risk for imbalance between calcium and phosphorus in your body. And more than a cholesterol, increase the risk for cardiovascular disease, okay? It's important phosphate additive in the US is a big problem because we have been fighting as a kidney dietitians to have that in labels. However, it's not in labels yet. I will recommend always to the patients to look at the ingredients section, and if they see that they have sodium phosphate, potassium phosphate, they should avoid them. And we see not only foods with phosphate additive, we see supplements with phosphate additive. I have a case, like I would say 2 months ago, that a functional doctor referred to me, and there, the supplements that they recommend, they have phosphate additive. And I was like, we have to avoid that, because increase, if the pH is not in balance, will increase the formation of calcium phosphate stones or crystals or microcrystals. Good sources of phosphate additive. I can talk about phosphate additive like 24 hours because that is, one of my passions about kidney disease and phosphate additive. Deli meat, frozen meat. One thing that I would say, tell you this, one of the most famous donuts in the US, I'm not going to say the brand, but will only do not contain one phosphate additive, has 5 different kind of phosphate additive added to one donut. This means that every person in the US, and this is one of the most popular donuts in the US, that eats 1 donut of that, of that particular brand, are increasing the risk for cardiovascular disease more than the cholesterol levels. Maybe the phosphate additive current imbalance, and then the cholesterol increase because of the oxidation, right? It's the way that they protect the body. But we need to pay attention to this. We have to, I'm sure that maybe there you don't have a lot of processed foods, but in the US, we have that. And especially the other day, I went to the grocery store and they have a lot of options like plant-based, dairy substitute, like hemp milk, like cashew, like coconut. However, when I checked the labels, they were all full of really important in case of PKD, I need to supplement sometimes, do special supplements. Calcium and magnesium citrate will help me not only to keep the balance or prevent the formation of kidney stones. Remember, a PKD, it has a deficient in cell level or mitochondrial level of calcium. And if we do, we provide calcium and magnesium with meals, that helps them to keep the balance. Electrolytes, I want you to, as I said before, when you follow ketogenic diet and it's natural diuretic, you're losing electrolytes, you're losing potassium, magnesium, you're losing, sodium. Vitamins and minerals are very individualized. Acetyl L-carnitine it's really interesting because we need carnitine to, it's like, let's say that you are in a train, you need carnitine to put all the fatty acid in the wagons of that train. And sometimes if you, one thing that happens when you start following the ketogenic diet is you increase, and that's the reason that when you follow ketogenic diet, start following ketogenic diet, you're more alert, more energy. Why? Because you increase in the formation of a mitochondria. And then in order, sometimes it's not, the production is a lot, and you need carnitine to put the fatty acid in the right, you know, in all the wagons that you need to continue keep the mitochondria healthy. Medium chain triglyceride is a technique or oil that we use to boost ketones. The body will not absorb, you know, as a normal fat, and it will help you not only to boost ketones, will help you burn more fat in your body. Exogenous ketone, we're going to talk a lot about it. Personal care, I encourage that with my patients because you can follow ketogenic diet. One thing that I want you to understand is ketogenic diet is a whole food diet. It's a fresh you know, foods diet. And one thing that ketogenic diet is not, is free of gluten. It's free of gluten. Most of the people, they have, if I do genetics, I say, like in my patients, I only have a case, only one case of all my patients that by genetics, she was not gluten intolerant. However, when I did further tests, she have a food she have a food poison episode, change the microbiome in the way that make her intolerant to gluten. Ketogenic diet is free of gluten. Exercise, sleep well is really important. Low oxalates, this is a big topic in the US. I have seen a lot of patients with not only kidney patients, other diseases. Oxalates is a relation with other diseases like autism. We found a lot about oxalates because the study that has been done with patients with autism. And it's really interesting because the only things that oxalates, you can, you know, you can only increase in your body with only the foods that you eat, but no, you have to take environmental factors too, like mycotoxins. Mycotoxins or mold increase the risk for formation of aspartate sugar, and then that the body will convert that in oxalates. That's the reason that when the patient comes to me and they have high oxalate level, or you know, the first things that I ask them is about environmental factors like mold toxicity, mold or exposure to mycotoxins in their body, in their house, or in their work environment. Candida overgrowth, increased oxalates too. It could be a genetic factor. There are some patients that I have that is a genetic problem. And for that, in order to see if it's a genetic problem, I do organic acid testing. Acid sparing ketogenic, really important. I would say that lemon juice is certainly important because it will dissolve all the microcrystals, will increase the citrate in your intake, and will decrease the formation of again, microcrystals and the formation of kidney stone. Intermittent fasting, time restricted, all depend on the patient. Adverse effect on ketogenic diet, we have some, but because we have you know, monitor the patient closely. This is really important to understand. When the patients are on ketogenic diet, it has to be under a healthcare professional, especially a kidney dietitian, a keto renal dietitian, because we can see the whole picture. We can prevent all the adverse effects. Metabolic acidosis, this is another factor I like always. And finally, the KDIGO guideline change. I like to keep my the serum bicarbonate levels greater than 24. I see if it is less than 24, increase the risk of the progression of the kidney disease or the kidney disease or cancer or any increase the progression of osteoporosis, decrease the growth in children's, progression of CKD, muscle loss, all of this. This means that it's really important. And I say, I'm writing a book right now, but I say that it doesn't matter where in the world you are, just try to keep the same, levels. That's the reason that we have guidelines. Kidney stones, low urine pH, low urine citrate, again, sources of oxalates, phosphoric acid, phosphate, and uric acid. It's really important to understand that microcrystal deposition increase and accelerate the formation of the cyst. This is a really important part that we have to monitor. Citrate supplementations, since affect in PKD, and dehydration. We need to keep the patient hydration fine. Citrate food sources, lemon is the most common that I use with my patients. Mineral carbonated sodas, I use it too, to keep the patient's bicarbonate intake high. Contraindication of ketogenic diet, obviously carnitine deficiency, and other things that right now, this histopancreatitis or things like metastatic liver cancer, all of this, we have to monitor closely or do the exclusion of to follow ketogenic diet. We keep the laboratory data really close, monitor closely to prevent further kidney damage. One thing that is interesting is like a lot of people or healthcare professionals in the kidney world, they only look at creatinine levels, and levels, but it's really important that creatinine can change with the body mass and can change with the protein that you eat. And cystatin C has been a better marker if you want to monitor that. This is an example of what kind of labs do we do in our patients. In the US, the exogenous ketones that we have available is a new product, just came to the market like 2 weeks ago. I'm still waiting for my sample. I never recommend, I mentioned this here, but I will never recommend a supplement or nothing that I have tried, especially in the ketogenic patients. I like to try, the supplements because I try at this point in 6 years on ketogenic diet, I try all the exogenous ketones that you can imagine. And I don't like it. I really don't like them, but I'm waiting for this particular product to come, and then it's a medical food, has to be prescribed by healthcare professionals that has been trained by Dr. Wayne's. Not everyone. We receive a training from Dr. Wayne's, and then and dietitians that are working from him. With him, and then we are the ones that we can prescribe these medical foods. It's not supplement, it's a medical food. We can use it as a medical treatment for a patient with PKD. And I will, if you follow my social medias, you maybe will see maybe later on how was my experience with keto, etc. Like 10 weeks ago, I have another aha moment was when the owner of a company asked me to evaluate a product that he has on the market since 2018. And I found that this is not a traditional keto product. It's no fat. It's high on polyphenols, has superfoods, 15 superfoods. And when I try myself, was the first one that put me in nutrition ketosis and faster than any product, even exogenous ketone. Furthermore, when you do exogenous ketones, you have to take like 2 or 3 doses a day, because increase the ketone bodies will decrease at 3 hours after. However, when I try this product that is high on polyphenols, will increase and will sustain. And it sustained my ketones level for more than 11 hours. And that's the reason I start to, to spread the word with my my mentors, keto mentors, and especially Basopac from the Charlie Foundation. It's like, we can say that polyphenols can create exogenous ketones too, based on my experience with this particular product. And if you see, one of the most potent foods that you can use with high polyphenols is the olive oil. And that's the reason I want you to encourage use more. Olive oil has been used not only to treat kidney disease and hypertension. It decreases hypertension. Okay, I want you to understand that in order to treat PKD, you have to increase ketones in your body, right? How you do it? Ketogenic diet, intermittent fasting or time restriction diet, and polyphenols or exogenous ketones. And all of them will decrease the cyst size, decrease fibrosis, decrease kidney size, decrease PKD progression, and increase function. In general, we have to lower blood glucose, control our blood pressure, decrease sodium intake, avoid excess of protein, no more than 0.8, increase fluid intake, daily lemon juice, ketogenic diet, reduce body fat, avoid oxalate if needed, avoid inorganic phosphorus, improve detox pathway, beta-hydroxybutyrate. If you follow like a well-formulated ketogenic diet, maybe you don't need beta-hydroxybutyrate supplementation. In the US, they're really, really expensive. And you can manipulate the macros. If you teach a patient correctly, you can do it without HB supplementation, but it's another option. Monitor kidney size and total kidney volume. Like I have a patient, and like I just received the results on yesterday, that decrease the size of the kidneys and decrease the volume too. And education, more education like we're doing today. Any question or concern that you have for me is welcome. It's a lot of information, but I want to spread the world that ketogenic can help with PKD.
All right, thank you, Teresa. That was wonderful, excellent presentation. Thank you very much. Really appreciate it. One question, Teresa, is on stage 3 to 5, because we would expect most of the patients that we see, especially in Africa, who comes with ADPKD are, on stage 3 or 4 to 5, some of them. So would you recommend keto diet in these patients who are in stage 4 or 5?
I have cases that they're stage 5 and there has been delayed they came already stage 5 and they delay obviously to be on dialysis. There's some of them that they don't want to be in dialysis or receive the transplant. My first patient that I have with PKD, when I always ask them, which one is your goal? And he say, I want to be 50 years old without, no in transplant, no on dialysis. And he just turned 50, like, I would say like 9 weeks ago. And we celebrate together because his dad died of, when after the transplantation because of PKD. The main reason, remember, the main reason of the progression of the PKD is diabetes, hypertension, and it doesn't matter. I have patients like, I just have a case like she started ketogenic like in my protocol, and she increased like 14 points in GFR. She's almost normal now. You know, it doesn't matter that they're stage 3, 4, even 5. If you teach them and do personalized ketogenic diet, you can decrease the progression, or in some cases, few cases that I have, you can probably reverse the progression of the disease or stop. My goal with each PKD patient is, okay, I have PKD. Okay, I have PKD. It's in my curriculum, like, you know, it's in my curriculum, but I stopped the progression of the disease. How I did it with ketogenic diet. Yeah. And remember, yeah, I say based on my experience, yeah.
Chat box.
Yeah, I can go. They say, what will be your general comments of ketogenic diet and advanced chronic kidney disease for diabetes? No diabetes on and off, hemodialysis, peritoneal dialysis. I would say probably the patient is on and off. I would say ketogenic will maybe stop to be on dialysis. Again, it just visualize that it decreased inflammation, it decreased the insulin secretion, it decreased the fluid retention, sodium retention. They will not have that factors that will put them on dialysis or PD. PD is a problem because they get like solutions with glucose, and that's a big problem. They say, thank you for the nice presentation, that the ketogenic diet is safe for hypertensive CKD patients. More than that, is super safe because it will control the hypertension. Obviously, again, visualize if I eat carbohydrates, I'm going to increase the insulin secretion, increase fluid retention, sodium retention, will increase hypertension. If I stop that, that will decrease the risk for CKD progression. Animal versus of plants, which one is recommended as a source of fat and protein? I would say we have to have a balance between them. If the patient prefer, obviously, we are going to prefer plant-based. Why is the reason of that? Is because we want to keep alkalinized the body, the most alkalinized that we can. Alkaline, we have to keep our pH in blood greater than 24, and pH, and then urine pH at least greater than 7. Ideal is greater than 7.5 because you're cleaning at cellular levels. But I would say that is a balance. In terms of fat, we can, you know, do a well-formulated ketogenic diet. You can do like a clean ketogenic diet and add good fats like avocado. Avocado by itself, in avocado oil or avocado by itself, increasing your body the formation of glutathione, and glutathione is one of the most powerful antioxidants that you can provide to your body, right? Asparagus, things like that, like for example, asparagus increase glutathione too, berries increase glutathione formation in your body too. You can do the clean fat, you know, animal products, and then add good fats like olive oil, you know, to your meals. In terms of ketogenic diet for patients with inflammatory bowel disease, yeah, we use it. We have patients with Crohn's disease, IBS, that we has been, I think it was not in the list that I show you guys as a option. Is there has been cases with IBS with ketogenic diet. And again, it's because we're decreasing inflammation. What is the effect of ketogenic diet on dyslipidemia and diabetes? That is a good question. One thing that, and I didn't mention because I didn't want to, that story about cholesterol is killing people is not right. When you do cholesterol levels, when I look at the lipid panel, the first things that I look is interesting, because I put even that in my book. It's like, you can see how normal triglyceride and normal HDL And what it is telling you, if you are increasing the risk for cardiovascular disease, is the triglyceride HDL ratio. If triglyceride HDL ratio is greater than 2, obviously you have insulin resistance. And this is interesting because you see like a lot of panels there that they say that is normal, but when we look at that, it's not. Another thing that about ketogenic diet is increased LDL level, but since 2013, even the American Heart Association, we cannot look at a single marker for cardiovascular disease, LDL. No, we even the study has been done, increased LDL level. However, when we do the labs, that we do an additional labs for that, we do LDL, what we call LDL particles. And when we do the LDL particles, it shows that, you know, they're the big and fluffy. When you have the apple B is like big and fluffy, decreased cardiovascular disease. When you all have the LDL particles that are small and dense, they're the ones that attach arteries, and they're the one increasing cardiovascular. I would say look more further about you know, about LDL. LDL is not the only marker. And I don't know if since forever, you know, since the 80s when I started studying in the college, you guys, when you open a book about, I can open any book about kidney disease and nutrition, and they say that the survival is more when they have high cholesterol versus low cholesterol levels. You know, and again, it's not about cholesterol. We have to look further. We have to look how are the particles of the patients. This is interesting. Look at I heard about polyphenols cause ketosis. This is what I found with these products, and my theory is, okay, I took a dose of these products, and when I took a dose, it's a lot of plenty of research about how polyphenols increase the beta hydroxybutyrate or increase the formation of short fatty acid, and especially butyrate, right? And then there's a lot of studies that, you know, like shows that polyphenols could increase the benefit of polyphenols, decreasing inflammation in your body. But if you connect that, my theory is, based on what I have and experience with these products that I have, is when I drink it, because it's high on polyphenols, it's increasing the formation of short chain fatty acid, it's increasing the butyrate, and butyrate is increasing the formation of ketones. And again, this is something that I discuss with my mentors, but they have the same theory. I believe that it happens, but was not until I have the experience. I think I had never had the experience before. And again, I has been trying so many products that is for ketogenic diet, and none of them, even exogenous ketone, was able to do that to me. And not only to me, I start using that with my patients, and the same results. And obviously, we are going to collect data. We're collecting data right now, and later on, we're going to publish about, yeah, that's my theory. Again, polyphenols increase short chain fatty acid, butyrate, and butyrate will increase ketones body. And it is interesting because in some patients, it's only in 30 minutes. 30 minutes, you need, I want you to visualize this. In order to be in ketosis and nutrition ketosis, you have to be fasting at least 12 to 16 hours to reach 0.5. You need to be fasting for at least 60 to 72 hours to reach more than 1.5 on ketone levels. However, these products could be, and not only me, patients too, on nutrition ketosis in 30 minutes. or 1 hour. We usually, it's really interesting because my recommendation is always for patient on ketogenic diet to check ketones body after 2.25 hours after their meal, right? 1 meal a day. And that will give you an idea of how high the patient is going in terms of ketones levels. And it's really interesting because it shows that even in less time, I was able to be in nutrition ketosis. I think I don't have more questions, right?
Yeah. So I think we'll get one comment from Dr. Lloyd. Would you like to comment?
It's wonderful. Thank you so much.
Before we allow
it's a wonderful
to finish her presentation.
Yeah, it's a wonderful presentation and so much of very interesting information. Just in 1 hour is really was very useful and a lot of new information for me at least. I learned a lot. In this fasting, how many times a week would one do intermittent fasting or time-restricted fasting? Is there any sort of limitation?
Fasting is really interesting because my personal experience showed me when I was getting blind, that was the way that I want you to visualize fasting the way that you clean your body, okay? And especially when you clean your body, like every 10 to 12 hours that you're not eating, every 10 to 12 hours that you're not eating, you're releasing toxins from your body, your fat tissue, accumulation of toxins in your fat tissue. When you do that and you start your day with adding like alkalinize your body, like plant-based, I like to do chlorella, moringa, all these foods that will bind the toxins and then we'll take it out. The thing is, if you do that almost daily, you will have, I always say to my patient, you take the trash out of your house every day. You have to take it from your body every day. How you do it? That way, fasting, like every 10 to 12 hours at least, and eat something that will help you to alkalinize your body and take the toxins out. One thing is that you need at least a pH of 7 to ideal 7.5 to really go at deep cellular levels and take all of that. And that's the reason that for me, ketogenic diet, it changes. I would say like 100% of my patients with diabetes, they reverse diabetes. Diabetes is the most easy way to be reversed if you follow low carb diet. It's the way to clean your body, is individualized. I don't want the patient that is obese or I want to do it in a slow motion, intermittent fasting. I don't want the patient that they're obese or have a lot of exposure to toxins to do it every day. I want to create on them a system that would take something to bind the toxins every time that they're doing the fasting. I don't know if I can explain that. Did I explain that well to you? It's individualized, but as soon as you create that system in your routine, daily routine, it's going to help you. It's going to help anyone. Okay.
Thank you.
But it's the way to clean your body, is the way to heal your cells, is the way to reverse any disease. It doesn't matter if any disease, any chronic disease, any metabolic disease in general. Yeah.
Thank you so much, Teresa. Wonderful presentation. Thank you very much. We really enjoyed it. A lot of new information too. Thank you.
Thank you, Dr. Lloyd, for a very good question. Teresa, thank you very much for this wonderful presentation. We really enjoyed it, and there are a lot of new issues and that has you have presented. Now it's for us to go and learn more and go through those issues. Thank you very much. So we have come to an end of our presentation today. So we'll see you next week on Thursday at the same time. Thank you.
Thank you.
Thank you, Teresa, and thank you, everyone.